Good afternoon, everyone. It's 12:30. Happy Thursday. Welcome to another edition of Newton-Wellesley Medical Group Lunch and Learn. Today's topic, Lab eConsults, time to meet the pathologists. We're pleased to have Dr. Michael Misilek here for us today. Next slide, Mike, if you could do. Just want to give everyone the CME code. It's NELDAC. We'll put that in the chat box and we'll also show it up at the end, NELDAC. As you guys know, it qualifies for 0.5 hours of CME. I did find out for people on this call that actually I used to say that you have 24 hours to submit this code. You actually have a full week to submit the code. So that's new news. Next slide. Just want to tease next week's Lunch and Learn and the following week. We have two cardiology talks coming up. One on the new technology, CT coronary calcium scoring, and then last about the next one about the lipid clinic, and we'll get November's schedule out to folks. As everyone knows, or I hope everyone knows at this point, these talks are archived on YouTube. Just go there and search Newton-Wellesley Medical Group Lunch and Learn. And again, the CME credits can be claimed for up to a week after. I'm now going to stop talking and hand it over to Mike. There you go.
Great. Thank you, John, for the intro. Well, welcome everybody. Pleased that we have a good turnout, and I'm excited that everybody wants to learn about what Lab eConsults are all about and an opportunity to know your pathologists who are here and working for you with the care of your patients. So let's start off. So the Lab eConsult team is a subset of the larger pathologist group. As you know, chaired by Dr. Guidi. The four pathologists who are going to be participating in these are myself, seated there, Dr. Todd Abbott on the left, Dr. Dan Kelleker in the middle, and Dr. Kenan Souter on the right. And the reason why it's a subset of the larger group of pathologists is that we expect most of the questions to come in to be related to something on the clinical lab side, meaning I've broken it down here in the parentheses for each of the pathologists. By far the number one question that comes in is related to toxicology interpretations. And I've been answering those usually via email. So I'll be handling anything in chemistry such as toxicology, and we'll go through a couple of examples of the types of questions you might want to ask. Dan covers hematology. Todd does cytology. We just recently had eConsult on a cytology question. I can talk about that briefly. Kenan will be fielding any micro questions from the microbiology lab, and Dr. Turner will gladly answer your questions about blood bank transfusion reactions, any sort of issues that you may have questions with there. So why offer Lab eConsults in the first place? What's been happening thus far is usually when somebody has a lab question, they're going to reach out to one of the pathologists via email or maybe even Epic email. We'll get that email, we'll respond to it, and that's the end of the encounter. And then what I've noticed is that sometimes those emails, there's no formal way to document them, to save them. And I've noticed some providers will copy an email into the medical record. And we thought that was, it may not be entirely compliant. We want to tighten it up and take advantage of the full value that we can deliver as pathologists here and help you take care of your patients. So the eConsult module is a perfect vehicle for that. It can formally capture any advice that the pathologist gives to you, become part of the medical record, and ultimately, hopefully lead to better patient care. So what is and is not an eConsult? So whenever we're asked to render some sort of medical judgment, it's not going to be for a curbside question about a critical value. Why are these flagged as high? Or geez, MGH flags their potassiums at this and we do it at this. It's not that. It's not easy things like that, quote easy, where we could it doesn't require a comprehensive review of the medical records and sort of a distillation, the larger picture of what's going on. And I hope with the next few examples here that I show, it'll become more relevant to you about exactly what constitutes a lab eConsult. So just to reiterate, the different departments in the clinical lab. So the pathologists here, we're in charge of both sides of the laboratory, meaning the clinical lab, which is composed of chemistry, microbiology, hematology, and the blood bank. And then the other side of the hallway, if those of you who've been down here to the lab, and if you haven't, I welcome you for a tour, is the tissue side, where we process all of the biopsies, the resections, anything that comes out of the operating room that gets made into slides, and we read those here in our offices under the microscopes and render diagnoses. So that's the anatomic pathology side of the department. And those questions usually come through in the format of a tumor board or in the substance of the report that we issue. So we feel that that's pretty well covered. And those are kind of one-offs with the submitting clinician, pretty straightforward. The clinical side, though, is where these questions come up that are really hard to capture somewhere in the medical record to document and hopefully learn from going forward. And that's why we feel the eConsult is a great application to do this. So the way we go about finding the lab eConsult is just search for lab econ, and you'll see it get pulled up here, ambulatory Newton-Wellesley laboratory eConsult. This is the next screen you'll get, which says laboratory eConsult is not intended for patient outreach requests, but, and that's another point worth mentioning is if a patient calls you about something, this isn't really the venue to sort of relay that message to us, but rather to act as a resource for clinicians to request information on laboratory related questions, such as toxicology interpretations, blood smear reviews, any confusing coagulation interpretations, infectious disease test results, transfusion questions, et cetera. And just give us 2 days to get back to you. We have our practice manager in the pool to receive these questions, and she will divvy them out to the appropriate team member. And if one of us is absent, there's somebody to cover for it. So there shouldn't be any gaps in coverage there. So let's jump into toxicology, and I'll give a couple of examples. And I'm really thrilled that people have already found out about this even before this formal go live. We sort of had a soft launch where it was available for a couple of weeks now, and people have found it already, and I've already fielded maybe half a dozen questions, and most all of them are toxicology related. And I suspect when this information becomes more widely available, that an eConsult is available, I think people are going to be asking more frequently, because I bet many providers may look at a result and think about it. Something may look funny, but then just kind of file it in the back of their mind and not really know who to ask and not know that this service is available. But having it now available, I bet we're going to see it be a big help to providers. So the sort of big categories that come up when looking at a tox screener, is there an unexpected positive or negative result? And that's the drug screen that we run in-house on urine. You may be questioning whether there's suspected adulteration or substitution of a specimen, meaning somebody has swapped out the urine or added something to it. You may be wondering about the sensitivity of the test, whether we need to do more testing, such as a confirmation test, or it could just be a challenging interpretation. A patient is on multiple medications. There's an unexpected positive or negative there. You don't really know why. This is a perfect opportunity to reach out, and I'm glad to help you go through this. So You can see this was just a couple weeks ago, 9/24. This came in, patient on long-standing oxycodone, no concern for inappropriate use, though last urine tox was negative for oxycodone, which she takes consistently. Would need, when would she need to take the last in order to see it in the urine? Should we do the next urine with test for metabolites? So this is a question of, you're expecting to see a positive oxycodone, your patient is taking it, and why isn't it positive? I'm not worried about diversion, but you never know what's happening. So this is a great opportunity to reach out. And I also want to use this opportunity here to just talk for a bit about toxicology and kind of the breakdown, because of the questions we do get, toxicology is number one, and I'd say the number one of that relates to opioids and unexpected positives or unexpected negatives. And I think the case illustrates a couple of nice points that are worth clarifying for the group. And this is a breakdown of opiates in the body. Now, the tests that we do in-house, the tox screen, has opiates on it as a class, but it also has oxycodone, which you'll see up here, breaks down to oxymorphone. Now, the opiates, our assay in-house really is most sensitive to codeine, morphine, or heroin. So any of these would tick positive, most certainly. Oxycodone will not give a positive opiate result. And because of that, oxycodone is a separate line item in the tox screen, and you'll see that resulted. This patient, it was negative. We should definitely see oxycodone on the screen if your patient is taking it. And a good rule of thumb is if they've taken a drug within the past 2 to 3 days, it should show up on the screen. A couple of important points to remember about the opiates assay that we offer here is, as I mentioned, it targets morphine. So direct derivatives of morphine, such as codeine, heroin, are very readily detected. It's got lesser reactivity with hydromorphone, hydrocodone, dihydrocodeine, oxycodone, and oxymorphone. False negatives are absolutely possible with the semi-synthetics and the synthetics. So fentanyl does not give a positive opiate, and because of that, we have added it on the screen, as well as buprenorphine. Any of the synthetics, as a rule of thumb, will not be very sensitive in the in-house screen. So the way I put this together, and the eConsult will come across in Epic, it'll be viewable as a regular note with history, pertinent, I like to put in pertinent medications, pertinent lab results, and it's just a very targeted note, like you've all been accustomed to eConsult with other specialists. If you ask for an eConsult from hematology or cardiology, it's exactly the same format. So here, what I said is the negative screen for oxycodone doesn't entirely rule out the possibility that there is detectable drug present. It could just be below the level of detection of the screen. So that's always something that holds true. The screen in-house has to be set at a particular cutoff level. And it could be the patient's metabolism, the dosage that they're on, the interval from when they've taken the last dose, that it could be just below the screen. It would screen negative, which is probably what happened in this case. And the question is then, what do we do? So I offer here a good suggestion. This is a good scenario to get the confirmation. We generally hold on to specimens in the lab for 3 days. So the sooner you can review your results, and if you have a question, get back to me would be great, because chances are we'll still have it and I can add on any testing that we need to do. So I offered here, it was beyond the viability of the specimen. We had tossed it out, but on the next visit, I told this provider to go ahead and order the pain management panel. And that's a confirmatory panel. It's done by a little different methodology in-house here. Our screen is a immunoassay. The confirmations are generally a mass spec technology, which measures down to a much lower level, and it actually will quantitate out and give you an exact number. Here's another question that came in just a couple days after that one. Another toxicology interpretation. This one, 71-year-old male on chronic lorazepam for years, takes it every night. However, the last 2 urine screens have returned negative for benzos. Any logical way to explain this? And then there's a second question here. He also takes chronic Percocet and the opioids were positive. So we just ran through that. So lorazepam, it's a benzodiazepine. Why shouldn't it show up? We screen for it. You order the urine tox screen. There's a line item for benzos, and it's negative. So here's another great pearl. As with the opiates that are most sensitive to codeine and morphine, the benzos are most sensitive to oxazepam and nordiazepam. So the further away you get away from these in terms of derivatives, whether it's breakdown products or other benzos entirely, such as Ativan, Xanax, Versed, Halcyon, these may not be well picked up by the benzo screen. So if you've got a patient who's taking Ativan, you screen them, they're negative, that's not entirely unexpected for the immunoassay that we run in-house. And this is holds true for all hospitals that do an in-house screen. It's generally the same methodology. And it's just the chemistry of the reactions is such that the nature is that oxazepam, nordiazepam are the most readily detectable. In order to detect the other ones, have to have much higher doses, much more frequent dosing, a higher level within the blood. So what do we do here? We've got a negative result. Patient says they're taking it. Negative benzo, what I did here is I exactly explained this chart here. The urine screen is most sensitive to either oxazepam or nordiazepam. It detects poorly those other benzos, and false negatives are thus possible. In fact, the most commonly prescribed benzos may not be detected well. And particularly other agents that patients may be using for sleep, which are technically not a benzo, Ambien and Lunesta, are not detected at all. So in this scenario, you could order a benzo confirmation up front in addition to your urine screen. And this is this EPIC code here. Unfortunately, this patient, the urine had been discarded. The next time they come in, I recommended to the provider that they order that test. All right, so tox screens. The number 2 question I probably get is related to electrophoresis and immunofixations. So you're following a patient with MGUS, or you've got a patient with high calcium, and your very first screen here is that you want to you want to rule out a plasma cell dyscrasia. So you decide to order an SPEP or an IFE, and a question might arise there. So this is just for reference. I just wanted to show actually how these are done. This is one of the few tests that we still do in the hospital that's really manual and entirely dependent upon our eyes as a pathologist looking and reading this. It is not automated. It's not something that we just plug in a machine and it prints out that there's an M spike. We're actually going to read for it, and I'll show you how. So in this lane 10, these bands down here are albumin. That's the normal protein that's most prevalent in blood. The smaller bands, as we go distally from there, are also normal. Here's a normal control, and we see a band here. So this is an M spike. Incidentally, this patient also has one, this one does, and this patient. So the next step in the workup here is if it hadn't been ordered up front, the pathologist will generally reflex an immunofixation, which is this plate on the right. And that is used to identify what type of band this is. Just knowing it's here, we don't know anything about its identity. Is it an IgM? Is it an IgG? And what we do here on the IFE is run different antibodies. So this patient down here, if you look, that's the same exact lane. You can see the M spike. Now we can put an IgG antibody, an A, an M, a kappa light chain, and a lambda light chain, and we just read straight across the plate, and we see that this is an IgG kappa. Now, a lot of these questions may sort of overlap with hematology consult, and we're in no way trying to step on their toes or take any business away from them. But as far as the technical details of doing it, interpreting it, if you have questions about why a band didn't appear or why this seems like it doesn't fit with the patient's history or what might be the next step, happy to answer those types of questions. And I will quickly pull in our hematology colleagues if I don't feel comfortable or suggest that you do get further info from them. Another question we're getting frequently a lot is related to COVID. And obviously, it's a very relevant topic and something that I'll just run through one question here and it'll bring up a couple of good teaching points. So you've got a patient who had a positive COVID PCR, asymptomatic, completely fine. And for some reason, 3 weeks later, somebody ordered antibodies. Now, all we heard about through the pandemic, the first surge, every day on the calls, Dr. Leibowitz, Dr. Snyder, even myself, don't order antibodies, especially if you've got a positive PCR already. We don't know what they mean. And I would say that that still holds true. Yet somebody out there ordered one, and it's not impossible to order one. You can get by in any stops, but it had been ordered. And this is one of the reasons why we had been telling providers not to order it. So the antibodies came up negative. What does that mean? So this was a question that I fielded. I won't tell who ordered the antibodies. So what I did is I went back to the patient's original swab, their PCR, and this is just to illustrate the type of work that you'll get with an eConsult that is more than just kind of the hallway talking about a lab value, but this is why we need this eConsult vehicle to sort of put this together in a formal report. So I went back. So one of the questions would be, could this have been a sample that got mixed up? Was it a low positive? Was it not? Was it like just above the limit of detection? You may have heard about the CT values. That's in PCR, that's the number of cycles that PCR runs until it detects a positive result. And for this patient, it was 23, which is a lower number, meaning it's not entirely correlates to, but it correlates to a higher viral load. So this was definitely a true infection. So the next thing I did was I looked at the antibody test that we run in-house. So we do offer COVID antibody. We run it on our main chemistry line, and it's a total antibody that looks at both IgG and IgM against a nucleocapsid protein on the inside of the COVID virus. The cutoff value here, the coefficient COI was 0.069. So in order for the test to report positive, that has to be 1. So this is definitely a negative antibody. And we have certainly seen patients who have low antibody responses where it's single-digit numbers, and even some of the newly positive cases can be up in the hundreds. So that's definitely a negative number. And it was run 3 weeks after the PCR. So it should have been positive. Most patients will seroconvert within 2 weeks after having been infected. So it brought up another question. What's going on? Is this patient immunocompromised? Are they not immune? Are they susceptible to being infected again? And here's something that is worth drilling down and also emphasizing why the antibody test is not great. So for asymptomatic patients, the in-house antibody test that we offer is this Alexis anti-SARS-CoV-2, and you'll see the detection rate is only 62%. So can be a lot of negatives. Not a great test. So please still refrain from ordering antibodies at this time. I'll briefly finish here. I'm a couple of minutes ahead of time, but maybe we'll have some questions here. For those of you who joined late, just to reintroduce the lab team here, standing in the back, going left to right, Dr. Abbott. He'll field any cytology questions. And to give you an idea of a cytology question, one we just got a week ago was a patient. I've done a pap smear on them. It's come back unsat. I brought them back to the office. I did another pap smear, and again, it returned unsat. What can I do? And Dr. Abbott graciously answered that question. Dr. Kelliker in the middle, in the back, hematology, myself seated, will handle any of the chemistry questions. Dr. Sauter for microbiology, and Dr. Turner, who is in our extended group up at North Shore Medical Center. He's the blood bank director for both up there and here at Newton-Wellesley, and he's always available for blood bank questions. All righty.
Thanks so much. Really great talk. I have a quick question about the process. So it was really interesting to see your comment about lorazepam and Xanax, probably the 2 of the most common benzos we do use. So if we get a negative, can we just do the lab add-on and write confirm benzo or confirm opioid? Is that the best way to get that done quickly?
Yeah, definitely. Lab add-on, and we'll be able to run that.
Don't add on the whole pain medication profile, because that's quite expensive. Right?
Yeah, that's an entire that'll give you like 30 different opiates and methadone. You don't need all of those. I think just a targeted benzo confirmation, it'll be cheaper too.
I don't see any other questions in the chat box. If people want to either unmute themselves or type it in, the code is on the next slide, NELDAC.
John, can I ask a question?
Please go ahead, Len.
Does the laboratory publish a list of bacteria that you're seeing on cultures and the sensitivities for the community?
I believe we do. I can get that. I can talk to Dr. Sauter about that and get back to you on that.
Yeah, for those of us practicing for a while, we used to get a little handy card, I remember, that had the pluses and minuses of the different antibiotics and the different sensitivities. So that would be interesting.
Yeah, I can definitely get that for you. Thank you for the question.
Thanks.
All right. Well, I'm seeing there's no more questions. Really great talk. Thanks so much. We'll see everyone again next Thursday for learning about the coronary calcium score. Everyone have a great weekend and enjoy yet another week of NFL, which is great news. And I'll see you next week. Bye.